Welcome to my quality improvement presentation poster. Induction of labor has increased from 9.5% to 22.6% since the 1990s. There are pharmacological and mechanical methods for inducing labor. It's to promote a vaginal birth. The mechanical method that will be discussed today is insertion of catheters. Using Foley catheters, the more cost-effective and accessible for the hospital. There's also single and double lumen balloon catheters that are made specifically for ripening the cervix and inducing labor. Pharmacological options also include dinoprostone and oxytocin, along with other prostaglandins. The mechanical methods increase the pressure on the cervix, which then causes the Ferguson reflex to onset the contractions. It's important to only use medical indications for inducing labor and not due to impatience or scheduling on the physician's side. The risks that accompany induction of labor is NICU admission, hemorrhage, infection, low Apgar scores, cord prolapse, placental abruptions, and uterine rupture. The peacock question is, for pregnant women, is catheterization to induce labor lead to fewer complications or improved outcomes versus not using the catheterization method? There are many stakeholders. The stakeholders include the patient and their families, the obstetrician, the nurses, the surgeons, the NICU team, social workers, the physician, and the anesthesiology team. The potential barriers that come with these stakeholders is that sometimes the patient and their families are not educated enough and they don't know what's really going on or the risks involved. The residents do not have proper communication skills. They lack the interest, empathy when talking with the patients. The surgeons and the physicians lack the time and they're running in and out just to get consent, and they're not properly explaining to the patients the risks that are involved with these procedures. From personal experience, I just think time will be the biggest issue. Action plan. Action plan will be to have a thorough medical history of the mother. It's very important to know all the pregnancies that they've had prior, any surgeries or any C-sections, because C-sections or surgeries on the uterus causes scar tissue formation, which can cause uterine rupture, which is one of the biggest complications. It's very dangerous because it's overstimulating the uterus can cause the rupture. Getting a medical history is the most critical part. Women who have a previous C-section have 5 times the higher chance of rupture. Evidence has shown that compared to the pharmacological methods, the catheter shows no different in rupture rates compared with C-section patients. When we're comparing it to the prostaglandins or in the pharmacological methods, that the oxytocin has shown to increase the rupture rates. It's important to discuss potential situations with the patient before they happen so the patient is not only educated and knows the risk, but it can make an educated decision. It's also necessary to properly train the residents for them to communicate effectively and teach effectively with the family. Other resources that would be beneficial to the medical team would be proper documentation of all the labs and test results of the patient. Also having the catheter, the normal saline. The catheter will be in the patient from 12 to 24 hours. The higher the balloon is filled with volume, no longer than 12 hours, the increased vaginal delivery rates. The catheter balloon is not only more cost effective, but it produces less tachysystole than the pharmacological interventions on the uterus. The decreased risk of hyperstimulating the uterus makes it safer compared to dinoprostone, which is another pharmacological method. Compared to the medication, the catheter ripens the cervix more rapidly, but it takes longer for the fetus to deliver. Hyperstimulation of the uterus can cause respiratory acidosis in the fetus. That's why I believe that the catheter has more benefits in minimizing the potential risk than the pharmacological methods. The timeline of this project would be for a year. The way it will be measured is documenting all the medical history, all interventions, all the interactions with the patient and the medical staff. Everything will be documented, and then at the end of the year, all the pregnancies are going to be compared on an Excel sheet to then be measured and see where there's room for improvement to deliver safer care. The quadruple aim will be, my outcomes align with the quadruple aim because it considers the patient's safety first and the medical staff's involvement with the patient care. When the patient's receiving compassionate, informed, and safe care, they have a lower anxiety risk, and it reflects how they interact with their medical team, and the rapport they build and the trust that is built fosters an environment of open communication and collaboration between the entire interprofessional team, the patient, and their family. Not only does this improve the care being given, but improves the results of the entire population. And when the entire population has great results, the physician, the medical team feel great, they're satisfied not only with their personal life but their work life. And the catheters are much cheaper than the medicine, so it reduces hospital costs.